Greeting everyone. This is Dr. Lily Xiao. The title for today's talk is the Kidney Disease Screening and Awareness Program, KDSAP, Transforming Community Outreach and Inspiring Interest in Nephrology. Thank you for giving me this time to share with you. This is a very dear subject to my heart. This is me. And I involve in various positions, but it's all mainly a volunteer. But I must say to this talk, none of them play any role for today's content. In the next 30 minutes or so, I will first review a little bit with you, which is, I know you don't need it, but allow me to do so. It's epidemiology of CKD. Particularly, I wanted to talk about iniquity does exist in kidney health. I then will spend majority of my time share with you about KDSAP program, and at the end, I would share with you a little bit about why and how KDSAP can serve as a model. All right, according to 2019 WHO data, while in low-income country, the top 10 causes of death are mainly communicable disease. Most of them are infectious related. Among the high-income countries, though, the top 10 causes of death mainly are non-communicable disease, and kidney disease ranked number 8. And in 2017, during the Global Policy Forum in Mexico, the CKD was named as the neglected of the neglected, non-communicable disease. However, it is projected that kidney disease will be predicted to become number 5 cause of death by 2040. So instead of getting better, we are getting worse in terms of CKD. Now I want to switch gear to talk about incidence of end-stage kidney failure worldwide. This is using USRD data. The number 1, again, is Taiwan. Number 2 is the United States. But the point I'm going to make in this slide is the top 6 of the top 10 countries are now Asian countries. How about awareness of CKD? I'm using the United States data because it's very striking. Okay, this slide here shows very old data. However, interestingly, is identical. The awareness among the stage 3 are incredibly low, less than 10%. Those awareness for stage 4 is a little bit over 40%. Are we getting better in the United States? According to CDC 2023 data, for those with mild CKD, we are not getting any better. 9 of the 10 with a CKD stage 3 or less do not know they have the disease. For the severe one, meaning stage 4 above, we do a little bit better, meaning 1 out of 3 now know they have the CKD. Little bit better than back then, only 40%, but still not good enough because this is a group, should be everybody know they already have the disease. How about among the practitioners? I won't go through the detail. This is, again, is United States data. We're not getting any better. Only those who CKD stage 3 or less than 6% get referred to nephrology. Those are stage 4, is about 30%. This slide shows the 2 different studies and they are identical results. And this is still not good enough. The next I wanted to emphasize is kidney health inequality exists. So as we all know, ethnic group is less likely to be reported as a high-risk population for those with a kidney disease, especially among the low-income countries. And while the whole world, everybody doing a very good job focusing on the obvious risk factors, such as hypertension, diabetes, cardiovascular disease. But when it comes down to high-risk ethnic groups, we all fail. From the low-income country to the high-income country. How do I start a kidney disease screening awareness program, KDSAP? Make a story short, 1999, when I first moved to Boston, I received a lot of phone calls for Chinese people. They call me, the only reason they told me because I speak their language. So, which prompted me to realize that the factors preventing Asian population to seek medical care in the hospital for mainly two reasons. One is lack of health insurance. Two is a language barrier. I later on realized these barriers are found even beyond Asian population, and therefore serving the underserved, meet them where they are, it become my calling. And therefore, I created a program called Kidney Disease Screening and Awareness Program, targeting using a community-based, entering the community, meet community people where they are. And briefly, I created this program in 2008. I targeted a Harvard undergraduate student. If anybody thinks this program is unique, this is the only a unique feature, which is I target college student as a volunteer. And another important point is I focus on autonomy, meaning I let student has autonomy run the organization. And when I talk to undergraduate student, everybody told me they love the sense of autonomy. KDSAP has two branches. One is community outreach branches, which we train undergraduate students into the community, providing free kidney health screening. We also have an in-campus activity, which intentionally was rewarding the undergraduate student using their after-school time. We can go into the community, serving the community. So this program now turned into a sort of kind of career development program for the undergraduate student, for KDSAP member. So let me focus on the first branch, which is a community branch. We emphasize KDSAP is the core spirit is serving the community. And we make ours mobile, like I mentioned earlier. We don't wait for the community people come to us. Instead, we go to where they are, and we provide all the services free of charge. Meanwhile, we empower our undergraduate students with simple kidney disease knowledge so that when they enter the community, they will be the ambassador, raising awareness among the community people. We also teach our volunteers concept of partnership. The key important is to partner with local communities. Let them feel they are doing something good for their community and they deserve the credit for the event collaborating with us. Needs assessment, I wanted to emphasize that this is just an example. The first time, 2009, we entered in Chinatown. The key point of needs assessment is have the mentality allowing the community to educate us what their community like, what their community about, so that we will be able to serve them better. So the free screening protocol, we copy NKF and National Kidney Foundation KEEP program, Kidney Early Evaluation Program. Okay, so I don't deserve any credit. The credit should go to NKF KEEP program. So the content we provided here is identical to the KEEP program. We have the registration, we have the questionnaire, then we have a blood pressure station, we have BMI and waist circumference station, we have urinary station, blood glucose station, and the end we have a physician sit at a consultation, go over the screening result with the community people. Meanwhile, if the time and location allow, we also provide health education. This is an example of our volunteer entering Chinese elder home. Going to elder home is one of the favorite of volunteers. As the last, on the right corner, you see at the end of screening, elders prepare food for our volunteers. And our students got a wonderful meal of the day, and elders got young people keep them company of the day. Everybody's happy. We also conduct our screening in the Chinatown. As you see now in the slide, upper level, number 3, our students clustered together, while they are attending the questionnaire, they also take the opportunity educating participants as a little bit knowledge about kidney health. We also go to Korean church. In Korean population, we learned that majority of them are Christian, so the best to capture Korean population is going to this population Sunday after church. We also go to African American communities. We go to homeless shelter. To go to homeless shelter, this figure shows. We conduct the screening starting 5 p.m. because this homeless shelter provide dinner around 6 p.m. So by the time we finish our work, usually it is, and we get home usually around 10 p.m. So this is what I mean by assessing the community, knowing what is the best way to serve them. Like I say, we also provide a lecture on kidney disease prevention and awareness in the community. We do that in Chinese church, in culture center, in the restaurant workers and elder weekly meeting. These are just a few examples to show you. Okay. The next I wanted to talk about the in-campus activity. The in-campus activity, like I say, unintentionally now become a student career development. And we have a few programs, such as Meet the Professor or Doctor Colloquium. I usually invited my colleagues to come to the campus, meet the student, talk about their career, talk about their choices, about their life, work-life balance. We have another one is Meet the Patients Speaker Series. In this series, we invited patients come in to meet student face-to-face, share with the student about their own disease, teach the student about their own disease in patient's own word. Meanwhile, share with the student what kind of physician in their book consider a good doctor. We also conduct universal precaution and professionalism training. This is a mandatory training for any volunteer need to enter the community conducting screening activity. We also provide a blood pressure training workshop, teaching students how to do manual blood pressure. And it become also very popular series as well. Another unique of KDSAP is KDSAP developed a hierarchical mentorship. What I mean by that is I recruit junior faculty fellows who in turn mentoring the medical student or undergraduate student and student subsequently mentoring the high school student, and which is a wonderful format to pass on anybody who ever learned about kidney or passion about serving the community. Because of the uniqueness of KDSAP, we now have over 30 chapters nationwide. We also have 2 chapters now in Taiwan, and we still keep going. Okay. So what have we learned from community-based CKD prevention? I'm going to share with you KDSAP experiences. We use the 2,300 participants, which is a very early stage when KDSAP first started. And we learned that among the KDSAP cohorts has a very high awareness of diabetes. In KDSAP cohort, we have the diabetes awareness of 26% compared to the CDC data, which is about, I think it's 23%. Hypertension awareness among KDSAP cohort is very high, 36.8%, compared to CDC, which is, I think it's only about 16%. So KDSAP, indeed, using the community base is correct one, and we are approaching the right population who truly need our service. In addition to that, our data also shows that KDSAP actually has a high prevalence of, among the KDSAP cohort, we have high prevalence of hypertension. This paper published by one of my fellow who use KDSAP data compared to NHANE data, it shows that KDSAP hypertension prevalence is 67.5%, while NHANE is 45.6%. So it's incredibly effective for KDSAP using community-based model. How about proteinuria in the KDSAP participants in the community? We find that the prevalence of proteinuria among the KDSAP cohort is about 17.5% to 24%. I would have a slide coming to show you that in North America, the average proteinuria prevalence is about 8%. So KDSAP cohort is about 2 to 3 times higher. In addition to that, the awareness of proteinuria are very, very low, and especially among the young group. And I show you here, shown as the arrow, which should be at the red color. Okay. So by follow up by what is a finding in KDSAP, this is a meta-analysis from both United States and Canada. The overall prevalence of proteinuria or microalbuminuria is 8%. And as we all know that proteinuria or microalbuminuria, it has all-cause mortality much higher with adjusted HI is 2.1. And we all know that which can cause faster doubling serum creatinine and rapid progression to ESRD. One thing I want to point out here is a Taiwanese study, which I think is incredibly interesting. The Taiwanese study, they focus on head-to-head comparison with proteinuria and cigarette smoking. As we all know, we have been very successfully doing the cigarette cessation globally. And it's very successfully, and I'm very happy with it. However, when Taiwanese look at the cigarette smoking and proteinuria, their result shows that proteinuria actually have a higher all-cause mortality compared to cigarette smoking, and the lifespan is 7 years, meaning individual with a proteinuria has a 7 years of lifespan shorter than those who smoke cigarette. So while we are promoting cigarette cessation, why not promoting checking proteinuria? So the next level I want to talk about is why KDSAP is effective. Because we leverage resources effectively at the community level. And why is this? First of all, as you remember, KDSAP is a tap-in undergraduate student. And as in United States, most of universities are uniquely situated to serve the needs of urban minority population. Why I say that? Because in United States, according to 2018 data, the urban population, the minority make up about 43%. It's quite very high. Okay, compared to the rural population, only 22%. And in the United States, 2/3 of the American college are mainly in the urban areas. So because of this, KDSAP model, by mobilizing undergraduate students at the university and host the health screening in the area close by to the university, make it very convenient for the student to foster a wonderful relationship with its local communities, particularly those minority population. The second reason is undergraduates local community-based program, they can improve the trust. As we all know that in order to implement an effective early detection program for CKD in the community, one of our biggest problem or barrier is distrust of the medical team by many individuals. And one strategy to improve the patient trust is eliminate language barrier. And KDSAP model is good because we encourage each chapters to recruit volunteers with a foreign language experiences. Give an example, UC Berkeley chapters, they have been participate in inviting and partners with, they have a student group who are focus on language. Every time they go out community, they invited this particular student club to go out with them. This student group will be helping with the language translation or interpreter. It was wonderful, wonderful combination. The number 3 is KDSAP is using the tools, very easy to learn and to be trained. Okay, so KDSAP make it accessible to volunteer with a little training, and the tool we use is stethoscope, urine analysis machine, glucometer, a measuring tape, and scale, and they are very easy to learn. And in addition to that, is KDSAP conduct health screening is inexpensive. I won't go into detail. Anybody are interested, you're encouraged and feel free to email me. I'll be happy to provide more detail to you. Okay. To make the point of how powerful KDSAP influence other graduate students, this is an example of what KDSAP member did during the COVID, which is 2020 to 2021. While we are not able to go out to conduct health screening, our community service event shoot up by four times. You see here now, the yellow bar, which is incredibly impressive. Our volunteer students, they are on their own, take up into our hands, even though they were not able to go out, they still put their heads together, designing any program they can help the community in need by where they are. And this paper has been published by our student Kavya Shah. Okay. In addition, I want to another effect is KDSAP may serve as a potential model to address a barrier to shared decision making in CKD. As we all know, decision making for dialysis, for transplant, takes time. Participants they require more time to talk about the issues. But as we all know, time visiting in the hospital is it just never be enough. Okay, and so we have 2 students, Anthony and Noon, who published a paper on this subject. And a point I want to make here is they propose many ways that KDSAP can be utilized for decision making. And this, is, of course, can be including talk about renal transplant and dialysis modality. Okay, I'm going to switch gear to talk about how KDSAP can cultivate interest in nephrology. KDSAP, by cultivating interest in nephrology, by allowing student volunteering opportunities, also allowing them to have hands-on clinical experiences, and they have the opportunity to learn about kidney disease and their risk factors. In addition to that, they have opportunity working side by side with nephrologists. Okay. We also conduct a survey 10 years after KDSAP inception. We send the survey to our alumni, and the result we obtain, we ask our alumni what activity play important role in their career choices. And the number 1 is a health screening, not surprise. Okay. The second one is a career development event in the campus. Know that the physician, we also provide physician shadowing, but it's not the most influential factors to our student. Okay, I want to point out here that research is not the most prominent, mainly because that's not the main focus of KDSAP. So a little bit unfair. Okay. And we also ask our alumni their perception on nephrology. And that, I won't go into the detail, but the message here is any student involved into KDSAP, their perception about nephrology are very positive. We subsequently also published our paper on CJSET in 2025, and those have a collection of the reflections from our students and student alumni. So I want to mention here, because as we all know, as a nephrologist, we are very excited in recent years. For the CKD, we used to be only talk about progression, but I think in the future we may be able to even dream for potential regression, because the recent new category of drugs become available. However, I want to point out to you that while all the efforts still make at this area, meaning when the disease started, I believe we should also focus on identify CKD risk factors, and even before that, okay, because the data shows that doing early screening for the risk factor and identify a disease prevention indeed is cost effective. But currently, screening for CKD is still lacking worldwide. So here, I wanted to share with everybody some very good news for 2025. I'm sure all of you already know that, which is 2025 is a very good year for the entire field of kidney, right? And also very good year for World Kidney Day Joint Steering Committee, and also for KDSAP. Why do I say that? Number one, the historical day, May 23rd, 2025, WHO adopt a global resolution making kidney health as a global priority. This is the first ever in human history, I believe, making a kidney-related disease as a global priority. And I will shout out a credit to a group of nephrologists from South America for putting together this resolution. In addition to that, WHO also officially makes World Kidney Day the United Nations Global Public Health Day. So as a currently co-chair for the World Kidney Day Joint Steering Committee, I personally take a pride and feel very honored to have to see this happen. And thank you to our previous World Kidney Day members the past 20 years for all their efforts. And I want to emphasize here is the WHO highlights 4 key areas for making a chronic kidney disease as a global priority. WHO wanted to emphasize promote global awareness and education in CKD. And who are the group? One is increase public. In addition to that, also increase professional awareness of the CKD risk factors. In addition to that, they want to focus on preventive action through campaign and policy initiative. And I want to share with you, as up to this point, I hope you realize that this are exactly what KDSAP has been doing since 2008. So personally, I'm very proud of what we have been doing ahead of time. So in summary, KDSAP's community-based approach, particularly the underserved or minority population, is the right approach. I hope I has convinced you by now. KDSAP is an effective model to address kidney disease in the community level. And also you can use KDSAP to raise awareness of CKD. KDSAP can also to help identify at-risk individuals through its community outreach activity. The screening for CKD risk factors in the United States or high-income countries can be cost-effective. Recruiting undergraduate students as volunteers, as KDSAP does it, the model works in the United States, and it has proved to be a sustainable model. That's why we currently have 30 plus chapters, and it's still growing. So now I wanted to challenge everybody. When we talk about strategies of CKD prevention, how to early screening CKD patients, how to establish integrated care program. Can CKD serve as a community-based model? Will CKD work outside USA? I'm sure in our audience, some of you are not in the USA. I want you to think about it. Does CKD, KDSAP can be a model to where you are now? Okay, if not, who will be the ideal group or organization in the region to enter community? I want to end my talk by thanking many people. Most likely is the community leaders and members. Without their partnership, we won't be able to go this far in serving so many community peoples and learn so much about community. I also want to thank every KDSAP members, undergraduate student, alumni for their participation, for their love, and for their effort. Particularly also want to thank the faculty advisors and the university KDSAP chapters, particular faculty advisors for their love and volunteer their time to supervising college students. And I want to thank my past members and the staffs for their endless effort and helping KDSAP shaping up to the form that we are currently today. KDSAP already have 2 chapters in Taiwan and is still working, so we know that the model work, but we are curious whether it will work in other regions. So please feel free to contact me and share your thought with me. Thank you very much, and I will end it here. Bye-bye.